Pain has been defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage, or basically where the patient says it hurts. Pain, however, is always a subjective thing, and there is no definite way to distinguish pain occurring in the absence of tissue damage and pain resulting from damaged tissue. And of course, in terms of neuropathic pain, one may not see any significant changes either on physical examination or imaging, and yet the pain may be quite severe. However, in the cancer patient setting, pain as a somatic delusion or masked depression is actually quite rare, and that means that when the patient says they have significant pain, then they usually do. So on this slide of pain behaviour, it's important to remember that physical pain is the central issue, but then the patients experience emotions because of that pain and then elicit a pain behaviour. And it's the pain behaviour that we are able to either see or discuss with the patient. Now, the concept of total pain is different from suffering, but I've included them both here in this slide. It's important to think about the somatic source of the pain, because that's something that we can influence with our medications. So symptoms of the cancer itself, perhaps in some patients non-cancer pathology, the symptoms of debility associated with a progressive illness, and even the side effects of therapy. So that's the primary thing that we can look at, but then you've got other very important things to consider, such as depression, and that may be brought about by chronic fatigue or insomnia, loss of their job or prestige and loss of income, anger because of delays in diagnosis, unavailability of healthcare professionals, or because treatment just hasn't actually worked. And then the other important aspect is anxiety and fear. So fear of the hospital, fear of actually getting further problems with pain, fear about the future, fear of death itself. So there are a number of different components to pain. As we've already discussed, there's the physical pains that the patient has, and then there's important pain such as emotional or psychic pain, social or interpersonal pain, and spiritual or existential pain. And all of these are important, and all of these can make a difference to the amount of relief that we can actually give to a patient with advanced cancer-related pain. Pain is often used alongside the term suffering, but they are different and need to be distinguished. Suffering is the condition or distress associated with events that threaten the intactness and wholeness of the person. So suffering is made up of physical pains plus other physical symptoms or psychological problems, social, cultural and spiritual concerns. Suffering is also an aversive emotional experience characterized by the perception of personal distress that is generated by adverse factors undermining the quality of life. It is a phenomenon of conscious human existence. The intensity is a variable that is determined by the number and severity of the factors that diminish the quality of life, the processes of appraisal and perception. So, patient distress in cancer can be from physical symptoms such as pain, but it can also be from the other psychological symptoms that we've already alluded to, such as anxiety and depression. It may be that sleep disturbance is a significant problem for the patient. There could be problems with impaired concentration because of not only the physical pain that the patient has, but sometimes the drugs that are used to treat that pain. And there may be other significant issues in terms of CNS problems such as nightmares and delirium associated with progression of the disease and also the drugs that we use. So existential concerns that the patient may have, there may be disruption or distortion of personal integrity, So changes in body image, changes in social and professional function, diminished attractiveness as a sexual partner, and problems with increasing dependency on one's carers. There can be distress from retrospection. Patient may think back about things that they wanted to achieve but never actually got to achieve. There may be remorse from unresolved guilt from a former experience. Distress about future concerns, separation from their loved ones, a feeling of hopelessness and futility, meaninglessness about what they're actually going through, and concerns about death and what that involves. There may also be religious concerns. Sometimes the patient may think that the illness is a punishment for not having led a good life. There may be fear about what comes after death, particularly the fear of a total void. So there may be distress in terms of interrelationships, and in the healthcare setting for the patient with cancer-related pain, that may be distress in association with the family or with the healthcare providers or the healthcare system. And similarly, there can be distress that's caused by problems between the family and the healthcare providers as well. So it's important that these problems are sorted out as early as possible in the palliative care setting. And the way to do that, obviously, is good communication. Being available is also important, so that when the patients need to get seen and need attention, that is available to them. There needs to be appropriate personal and cultural sensitivity for the particular patient that you're looking after. In terms of being candid regarding discussions about their disease, I think that's something that occurs when you actually get to know the patient a little bit better. Obviously, patients and families require enough information. They don't want information overload, and they don't want to have a situation where they don't get their questions answered adequately. Now, there can be problems with the service itself in terms of lack of availability, services that are exhausted because they're not adequately staffed, and obviously that gets back to being able to finance a service adequately to provide an adequate service for the patients and families. Now, just looking at the difference between chronic and acute pain. Now, what we're dealing with cancer patients is sometimes a mixture of both, but there is a difference between acute pains and chronic pains. If we just go through the acute side first, that acute pain is usually associated with some acute illness or a particular injury. The time frame that we're looking at is usually measured in days or weeks. There perhaps is some purpose in having pain associated with acute injury so that the area is rested. Usually it's externally obvious. It may be a fracture or a post-surgical pain. And usually there's a timeline to recovery for the patient. Whereas chronic pain is a process that may go on over months or even longer. Because it's a chronic problem, patients can get depressed because of the pain and because they have problems living with the pain. The pain really lacks meaning. There's no reason to have ongoing pain. Recovery, unfortunately, is usually unlikely, and the patients need to continue on some form of therapy during that period of time. And patients who've got chronic pain don't usually appear as though they have pain, whereas a patient with acute pain usually has a sympathetic overactivity associated with acute pain.